Okay, looks like it's about 6:01. Kind of get started with our introductions. Good evening. Welcome and thank you for attending tonight's Ahead of Cancer lecture series sponsored by the Allegheny Health Network's Cancer Institute. My name is Michelle Studnicki and I'm one of the project coordinators for the Cancer Institute. Before we begin, there's a few housekeeping items that I'd like to review. Number one, during the presentation, all participants can type questions into the chat or Q&A portion of the Zoom. We will be addressing those questions at the end of the lecture if time allows. Participants cannot speak during the conference, but again, we encourage feedback via the chat option. Tonight's lecture is being recorded. If you're interested in rewatching this lecture or any of our past lectures, please check out our AHN YouTube channel. This entire lecture series is posted under the Ahead of Cancer playlist. Lastly, if you would like to schedule an appointment or have questions regarding a potential concern, please feel free to call our Hope line at 412-578-4673 or 412-578-HOPE. Our topic tonight is multidisciplinary care in neuro-oncology, and we are pleased to welcome Dr. John Herbst and Dr. Leah Herbst this evening. And I'd like to take a moment to introduce these remarkable individuals and showcase the impactful work that they're doing right here at the Allegheny Health Network. Dr. John Herbst, DO, is a highly respected neuro-oncologist with the AHN Cancer Institute. Dr. Herbst is dedicated to providing comprehensive care for patients with cancers of neurological systems, focusing on precise diagnosis and advanced treatment strategies. His clinical expertise includes specialized procedures such as the Ommaya tap, lumbar puncture, and administration of intrathecal chemotherapy. Dr. Herbst obtained his medical degree from the Lake Erie College of Osteopathic Medicine in Erie, Pennsylvania. Following his residency at Geisinger Medical Center in Danville, Pennsylvania, he completed his specialized fellowship in neuro-oncology at the prestigious Memorial Sloan Kettering Cancer Center in New York City, New York. He is board certified by the American Board of Psychiatry in Neurology and is actively involved in advancing the field through his affiliations with the Society for Neuro-Oncology and the American Academy of Neurology. Next up, we have Dr. Leah Herbst. Dr. Leah Herbst is a distinguished attending physician in palliative care at the Allegheny General Hospital. Dr. Herbst is instrumental in providing compassionate and comprehensive care, both inpatient and the outpatient settings, with particular expertise in the nuanced field of neuro-oncology. Her approach focuses on improving patients' well-being and supporting families through their complex medical journeys. Dr. Herbst is a Pittsburgh native and who pursued her medical education at LECOM, followed by a rigorous training, including an internal medicine residency and a palliative care fellowship at Geisinger Medical Center. Her experience in integrating palliative care principles with neuro-oncology teams underscores the importance of a holistic, multidisciplinary approach, making her insight invaluable for our discussion today. So I'd like to welcome Dr. Herbst and Dr. Herbst. First up, we're going to go with Dr. John Herbst. So thank you, and I will turn this over to you, Dr. Herbst.
Thank you for that introduction. Make sure I'm opening the right slides because we're doing this on the same computer tonight. So again, I'm Dr. John Herbst. I am the neuro-oncologist with Allegheny Health Network, and we're going to be talking about multidisciplinary care in neuro-oncology. A lot of this applies to general oncology as well, but obviously our focus is on patients with brain tumors. I'm going to start this talk in ancient Egypt because no one can stop me. Humans have known about cancer for thousands of years. The first published literature on the subject was the Edwin Smith Papyrus, which is currently at the University of Chicago, from ancient Egypt from around 1600 BC, give or take. And this has instructions on the resection of breast cancer, noting at the time that although the tumors could be removed, it did not cure the disease, and they did tend to come back. Other evidence for surgical oncology in ancient Egypt, we have several skulls which show evidence of patients with tumors of the head and neck that seem to have surgery on them. So this is skull E236 at the Duckworth Lab at the University of Cambridge, which is about 5,000 years old. I don't know how well you can see on here, the picture on the bottom left, you can see up into the nasal sinuses where there's a big kind of lytic lesion that was once there. And then much smaller lesions you can see around the skull, which were metastasis from this. And this is probably a person who had nasopharyngeal carcinoma that metastasized to the calvarium. I did not include the close-up images on the slide, but there are surgical cut marks near a lot of these tumors, which indicated that they did attempt to take some of them out at least. This is another skull from a bit newer, from somewhere between 3 and 600 BC. A patient with what was thought to be either a bone marrow tumor or a meningioma that growed through the top of the skull. On the pictures on the right, you can see numbers 2 and 3. There are one penetrating wound and another blunt area of trauma to the skull around the area of the tumor that showed clear evidence of bone remodeling, indicating that they happened before death and were probably related to attempts to surgically remove this tumor. Um, More recently, focusing on tumors inside the brain itself, we've known about tumors in the brain for many years as well. The term glioblastoma was first coined in the 1920s. Having microscopes at that point, they could look under a microscope and say, well, this looks like kind of like the glial cells that are supposed to be in the brain, but kind of like immature cells that haven't really differentiated yet, called blast cells, and it was called a glioblastoma. This is a paper by the great neurosurgeon Walter Dandy trying what we call a radical hemispherectomy. Patients with tumors on the right side who had no neurologic function left on that side of the brain um, were attempted to take out all of the brain that they could for these aggressive tumors after they had come back after an initial surgery. You can't really do this on the left side of the brain because that's typically where all of your language function is, but this was an attempt at aggressive surgery to see if they could at least be cured in patients who already had very significant brain damage from the tumors. Unfortunately, this was not successful. There were several patients which died in the perioperative period. One person lost a follow-up, and the two patients we do know who had longer-term follow-up on that, both of their tumors came back in different areas. This was specifically for glioblastoma, although the diagnostic criteria has changed since 1928 when this was published. But it does underscore that, despite the best attempts, these are not tumors that can be cured surgically. And unfortunately, glioblastoma is the most common primary brain cancer that adults get. So this is something that comes up a lot. Since then, we learned that radiation therapy can be beneficial for different cancers. This damages cancer tumor cells, makes it hard for them to grow and divide. And this has been used in all kinds of different cancers. But in the 1970s, we were able to prove that this did help people who had aggressive brain tumors after surgery. That people who got this radiation afterwards tended to live a lot longer and a lot longer time until their tumor came back. The radiation we have now is a bit better, and typically we're doing even a higher dose than this due to modern technology. But we were able to show even back then that, only the patients who got radiation were able to live past a year with this disease. Jumping ahead a little bit to 2005 is when we had our first FDA-approved chemotherapy for glioblastoma. The drug temozolomide was shown that when you combine it with the radiation and give more chemotherapy after the radiation, it also helped people live longer and have longer until their tumor came back. And although we were getting a lot more long-term survivors, generally we're still not able to cure this disease today. After that paper, we also learned, since that came out in the last 20 years, we've learned a lot in different cancers, including neuro-oncology, that the molecular features of tumors are really helpful at telling us how they're going to behave and what medications they'll respond to or won't respond to. So we learned something called MGMT methylation, which MGMT is a normal gene that you're supposed to have that's supposed to repair your DNA if it gets damaged. But unfortunately, it undoes what the chemotherapy does to the tumor. So patients who have this, gene very active and a lot of that protein going around don't respond to the chemotherapy as well. But people who have that gene not very active in the tumors tend to live longer independent of the treatment, but also respond much better to the chemotherapy. And this kind of molecular testing in oncology has really exploded since then, and there's a lot more we know about different mutations and the way they affect different cancers. Finally, we have also invented something called tumor treating fields to treat brain tumors. And it sounds very odd, but it does tend to work. And it's not specific to any type of cancer. There's a head version, there's a chest version that people can wear. The idea is that it makes a rapidly alternating electric field, and dividing cells need to use an electric field to line up properly and divide everything 50-50 between the two daughter cells. And this alternating electric field makes it really hard for them to divide. In the healthy cells of the brain, not a lot are really growing and dividing as an adult. So this does preferentially affect tumor cells. And once again, people who wear this device tend to live longer and have longer till their tumors come back. Um, so that was a quick 5,000 year literature review on, oncology in general and neuro-oncology, to catch us up to where we are today. Again, like I said before, in neuro-oncology, the most common thing we treat is something called glioblastoma. This is an aggressive brain cancer that we don't have a cure for. There are a lot of other similar types of tumors that can happen in the brain. Some of them we can cure and some of them we can't. But a lot of the focus has been on glioblastoma because of how relatively common it is within brain tumors and the fact that we still are very unhappy with overall the results we get from even the most aggressive treatments. Still, even with all of the newer treatments I talked about, few patients are surviving more than 2 years from their initial diagnosis. The care is very expensive. Brain surgery is expensive. 6 weeks of radiation treatments are expensive. There's a lot of side effects with radiation and chemotherapy. Some of them, only while you're taking the treatment, some of them that can be longer term as well. And despite this aggressive treatment, eventually we do expect that these kind of cancers will come back and create new symptoms and new problems that will require treatment and ultimately be life-limiting. There are a lot of different types of cancer out there, but tumors within the brain pose their own specific challenges. One of the most common things we deal with are seizures. In brain cancer, it's not the majority of patients that have seizures, but it is very common. They can be potentially dangerous in and of themselves, but they can also be debilitating practically for patients, even if you don't have symptoms all the time. If you can't get the seizures under control, people aren't able to drive. And if they have visits every, day to come in for radiation and every couple of weeks to check in with doctors and get lab visits or infusions, that can be very difficult for someone who can't drive. It's also going to be very scary to have seizures. Often people won't remember their own seizures, but family members don't particularly enjoy seeing their family or their loved ones, having seizures at all. Apart from the seizures, different tumors inside the brain, depending on where they are, can affect your vision and your movement. Weakness on one side of the body or the other is fairly common. Any tumor in the back of the brain called the occipital lobe particularly can affect the vision. This can affect patients' ability to take care of themselves and be independent, to get around the house. Even people who wouldn't lose their driver's license from seizures may still not be able to operate a motor vehicle just due to decreased reaction time or not being able to operate the wheel or the pedal or not being able to see enough of the world to safely drive. Cognitive issues can also be fairly common. These can be related to treatment. People have heard of something called chemo brain while you're getting your treatment, where it can just be harder to focus. But if the disease is progressing and more brain is involved by tumor, this can also affect people's ability to really, be awake and alert and understand what's going on and make complex decisions. And this is stressful not just for the patients themselves, but this is also very stressful for caregivers. And even as people who've taken care of sick family members can tell you, this can be really difficult. The neurologic decline that can happen with different types of brain cancers can be very severe. So, as with rapidly growing tumors, you can get a lot of swelling and mass effect in the brain. This can cause headaches. This can cause trouble with attention and focus and memory. This could cause very focal symptoms just in one part of the body. When it's related to swelling, often that could be something that's reversible if we fix the swelling, either with surgery or medications. Unfortunately, as infiltrative tumors grow, which isn't all the types of brain tumors in the world, but it is fairly common, more of the healthy brain is affected and damaged, and, it's not as easy to reverse that as it is to take swelling out of the brain. Ultimately, with different types of tumors we can't cure, as this progresses, more of the brain is involved, and people become more sleepy, generally weaker, less desire to eat and spend time, out of bed and doing things. And, eventually this gets worse and worse, and they eventually pass away. So, I mentioned how difficult this can be for family members and caregivers. There've been a lot of studies on this, noting that there's caregivers themselves that have a lot of symptoms. Typically, sadness, anxiety, irritation are very common. They note that the majority of them feel that symptoms of the patient negatively affects their family life, their social anxiety, their social activities, and it's very common to have a lot of financial difficulties related to that. Often, especially in younger patients who still would be being relying on a job with a salary to be able to, live a normal life. And, it can be very difficult to work in some of these cases. Studies on quality of life in caregivers and patients show that it really does affect both of them. So this is that same paper where caregivers were rating the quality of life of both themselves and the patients they were helping take care of. So 1 is the lowest, 7 is the highest quality of life. The left side here is the last 3 months of life, and then the one on the right is the last week of life. And you can see, on the right in the last week of life, the quality of life is pretty similar. They would rate themselves and the patients with the disease, not particularly satisfactory quality of life for either one. That's something we're always hoping to find ways to improve. Another issue, which I mentioned briefly earlier, is financial toxicity. So there's been, again, a lot of studies on this, that healthcare is really expensive. The more cool things we invent, the more money it costs to use all of them. So, this is just an example paper, but they're looking at financial toxicity. So how many people had significant medical debts related to their glioblastoma? So they saw nearly half of the patients with glioblastoma had a significant medical debt. So the average was about $7,500, with the median about $2,000. So probably there were some very, very high numbers skewing the average up, but still, that's, nearly half of patients with a significant medical debt related to their disease. Some things they noted that probably sicker patients tended to have more medical debt. So people stuck in the hospital longer, people who weren't able to get a full resection of their initial tumor tended to have more issues with financial toxicity and medical debt. It's not just the medical issues which affect this, though. We've known that socioeconomic factors play a very big role in this as well. Where you live, how much you rely on private or public insurance, and your job can have very strong effects on what the financial situation is. Unfortunately, we'd like to believe that insurance would be able to, cover everything for everyone, but in reality, even, patients with insurance, which was most of the people in this study, still a lot of them had significant out-of-pocket costs, and 18% of the people that they surveyed in the study were not able to afford the initial surgery for the glioblastoma. Practically, access is another big issue within neuro-oncology. It's a small field. There's not a lot of people who specialize only in brain tumors, and, we're kind of far apart. So, in a perfect world, we'd be able to get everybody on clinical trials and be able to do all this research and have everybody seen by subspecialists in the field. But realistically, just geographically, that's not possible. So there are a lot of places where the closest neuro-oncologist is hundreds of miles away. And this isn't just over the world. This is in, the United States and resource-rich areas where we have, all of these large research institutions spread throughout the country, and still, especially people in rural areas don't have access to what we have, here in Pittsburgh. A lot of people have to travel really significant distances to get subspecialty care and standard care, or they're, having to deal, they're having a physician closer to home who maybe doesn't have a comfort level or isn't fully up to date on everything within the field. So it becomes difficult for a lot of people to even get good regular care, let alone, trying to do more advanced things like clinical trials. So, what do we want to do to try to address all of this? So here within Allegheny Health Network, we've started our multidisciplinary clinic. This is something we've worked on expanding to get as much access as possible. And in this clinic, we have patients who will come in with brain tumors or even just imaging that may represent a brain tumor. And we have them see me. We have them see the other Dr. Herbst, who you're going to meet in a little bit, in palliative medicine. We have them see radiation oncology and neurosurgery, with the idea that, we're getting them to see all of these people who dedicate their whole life to treating brain tumors all at one time as quickly as possible so that we can get them the best care that is possible. So the goals behind making this MDC is to improve access and convenience for patients. So, they'll come in, they'll get put in a room, and they'll just see everybody in one visit. So they're not making multiple visits and drives over several weeks trying to meet all these specialists, paying for parking all these times and doing all these co-pays. The when we have someone who does have an aggressive cancer, we want to get them treated as soon as possible, either with, getting them into the OR for surgery or getting the radiation treatment planning done and the chemotherapy approved and sent. And that's often very complex discussions about the way to do that. But, we are able to do that very quickly here because we all talk and meet together. We review the case before clinic so that we all kind of are on the same page. We know that we're going to recommend and we know, where the treatment's going to happen, what's close to home, where this needs to happen, that needs to happen, if there's other tests that needs to happen. All of that basically happens in a discussion before the patient ever gets there. Another benefit that we wanted to do is to have a specialty palliative care as early as possible in advanced cancers. A lot, Dr. Herbst, the other Dr. Herbst is going to talk about that in more detail, but we know that that's just a good thing for everyone with advanced cancers to have early in the disease course as early as possible. And, there's a lot of recommendations from a lot of organizations out there, but in the real world, it's very rare that people actually do that. And we're lucky enough to have integrated palliative into our clinic because then we have that option for everyone at the very beginning of the disease course. And we'll talk a little bit later about why that's so advantageous for the patients. Just to get an idea of our workflow, again, we want to get people seen in our multidisciplinary clinic as soon as possible. So this is people who have known tumors, second opinions, brain metastases, not that infrequently just an abnormal MRI that someone doesn't know what to do with, and we help them figure that out. We can get advanced imaging very quickly. Last week, our nurse navigator, April, managed, I found out about a patient on Wednesday, and she managed to get scheduled a brain tumor protocol MRI, which is very advanced and has a lot of extra sequences in time for us to meet the patient on Friday and make a treatment plan before they ever came in. So in literally just 48 hours, we're able to get advanced imaging, have all the specialists see the patient, come up with the plan. If you just try to call and schedule, often you're waiting months to see providers, especially in something so specialized. As I mentioned earlier, we all discuss everyone before they get there so that, we should have a general idea of what we can recommend and what's going to be helpful for people before they get there so that they're not spending, 6 hours meeting all of us that day. And it's generally one-stop shopping. They come in, they sit in the room, and then they get to meet everyone. Medically, this is very beneficial because things can happen very rapidly. Often cancer can move very quickly, but this allows us to as well. If we need specialized tests, we can get them, and we know we need them before we even meet the patient. We work closely with our clinical trial team so that anyone new coming in, we can pre-screen for clinical trials before they come in, and then, have that as an option to talk about or even consent them for on the day they meet us all. Another thing is every big research institution is going to have different clinical trials in different departments that we don't all know about. So, our MDC allows us to talk with, providers and other specialties. So I have the medical trials and, Dr. Shepard will have the surgical trials and Dr. Wagner and Dr. Karlowitz will have the radiation oncology trials. So it allows us to be really thorough for everyone to make sure we're going over every possible treatment option that may be appropriate for them. This also allows us to go over big picture questions about how people want their care managed and what decisions they would want to make in the future, and just to think about overall the management of their disease throughout the disease course, and just getting a lot of those conversations to happen early. We don't want to just assume that this is helpful for people, so we are also doing this as an active research project. So, our pilot program for our multidisciplinary clinic, we were able to present at the Society for Neuro-Oncology meeting last November, and we're building a cohort of kind of historically how we've done within AHN as far as how we've treated patients, how much their healthcare has cost, how good we are at getting a lot of these discussions about advanced care planning done in the chart for people. And we're hoping that by seeing patients in our multidisciplinary clinic, we're able to minimize the time that it takes to get people in and seen and plan the treatment, and hopefully be able to help keep people out of the hospital by taking care of their symptoms very aggressively, and hopefully save the money that way as well, and overall just give them a better quality of life. And those are the big goals of our multidisciplinary clinic. So I think at this point, I am going to cede the floor to Dr. Leah Herbst and get her slides up.
Thank you very much. As he already said, my name's Dr. Leah Herbst. I'm from the palliative care team, and I'm going to talk to you guys a little bit about palliative medicine specifically, and then palliative care, how we do it in the neuro-oncology department. So what is palliative care? The way I like to describe it is that we work with anybody that has serious illnesses. We do a lot of different things. I put it into kind of 3 different buckets. We do a lot of symptom management. We help with kind of support in the kind of psychosocial, spiritual, other realm. And then we also help with difficult decision making to help make sure that what we're doing for our patients is what they want us to be doing. So kind of to start out with, a lot of people confuse palliative care and hospice. And so I just want to start off by kind of going over that so that you guys can have a good idea of what the difference is. For palliative care, and I'm going to go into more detail later, but palliative care is any point in a serious illness, and it is ongoing with life-prolonging treatment. And we're a subspecialist using our expertise to help the rest of your care team make sure that what we're doing for you is what's right for you. Hospice care is technically a form of palliative care, but it is not all of palliative care. It is an insurance benefit, so it's something that you get when you elect for hospice. And when you elect for hospice, you have to be at the end of your life. So we typically say somewhere about less than 6 months left of life, and we're no longer pursuing any of that curative life prolonging treatment. Hospice really becomes your everything at that point. And it is not necessarily, you can do hospice at home, you can do hospice in a facility, you can do hospice in the hospital, but it is not, they're not there 24/7. And so it is kind of all over the place. But our hope is, to separate out what is the kind of general palliative care here and what is that hospice care. So not talking anymore about hospice care. Where do we fit in? So typically what people thought of was this dichotomous model of healthcare where you do all of your life prolonging care, and then there's a cutoff point, and then we move to hospice care. Really what we're hoping for and what has changed with palliative care is that we do focus on care across the whole continuum. We are starting on patient-centered care and starting at the beginning. So you can see in that this chart here, throughout the course of the disease-modifying therapy, we're working on helping with anything that we can do to help make people support and give them better quality of life during their treatments. And then, of course, If we end up in a situation where we are at end of life, then we can transition to hospice at that point. But again, we could be there for any part of the disease, including people that have disease that we're focusing on with curative intent. So a big question that sometimes people ask will be, why did my doctor consult palliative care? Can't they just take care of it on their own? And really why we ask for palliative care and why I hope to help people is that we're a subspecialist. So using our expertise to assist with some of these really more complex things. So I'm going to go kind of over a few of these. We start with assistance with complex symptom management. So we're thinking about symptoms that are difficult to control. We want to make sure that people are tolerating treatments very well. So things like escalating treatment symptoms, refractory symptoms. Most of the time, we're thinking about things like pain, shortness of breath, nausea, poor appetite, any kind of difficulty with constipation, etc. We also help with that complex medication management. So, a lot of times you can throw kind of a bunch of different medications at people, but we want to make sure that what we're doing makes sense for the patient, makes sense with all of their treatment, and helps to keep everything kind of streamlined as much as possible. And we're addressing some of those other symptoms, things like anxiety, grief, spiritual distress, psychosocial distress. There's a lot more we know to cancer than just the cancer itself. We're also thinking about care for complex illnesses over time. Like if you remember the slide before, that whole trajectory of while we're in our illness, we're there to help. We're thinking about especially people with prolonged hospitalizations, frequent admissions. We can see people both in the inpatient and in the outpatient setting. And we're thinking about kind of that longitudinal care. The other kind of things, this is what a lot of times people think about as assistance with medical decision making and kind of determining your goals of care. So that's thinking about things like discussing your transition. So we're at point A, we have options for B, C, and D. What makes the most sense for me based on my goals, my treatment preferences? It's thinking about things like conflict resolution, thinking about, this person wants one thing, this person wants another thing. How do we make sure that this is the right thing for the patient in front of us? Discussing things like code status or de-escalating care. There's things that somebody is like, this is something I don't ever want to deal with. Thinking about complex family or social issues, like we talked about already. There's a lot of social issues and family dynamics that go into cancer itself. And especially any of these really advanced cancers, we want to make sure that we're taking all of that into consideration. And then we're thinking about questions regarding future planning needs, things like care planning, and setting expectations. So things like advanced care planning, figuring out who your medical decision maker is, making sure we have adequate plans kind of before we need them. So this is just a quick slide here on advanced care planning. I could probably go into like an hour's worth of talk about this itself, but I will not for right now. We think about living wills or advanced directives for anybody, like literally anybody, but especially people that have any sort of advanced illnesses. And a living will isn't like a document that you have that's signed, you can't change it after you do it. A living will is a working document. It's something that you start and that it starts the conversation, but it can change based on your preferences as your disease progresses. We have one through AHN. That's the one I typically use for my patients. That just goes through everything. It goes through things like CPR, breathing tubes. Do you want dialysis? What things are important to you at the end of life? What things are important to you during your life, during your illness? And it really just, the point of it is to open up that conversation and have it before you need to. Because when you have the conversation after you've already become ill, it's a lot more difficult. And if you don't have the conversations, which is what we see for a lot of people, because it's hard, and we totally understand that because these are not easy things to talk about. But when you don't have the conversation before you deal with it, it makes it a lot more difficult for families, especially when you have a patient that is not able to communicate anymore. And that very typically happens here with our patients in neuro-oncology. So the things that we kind of think about in palliative care and why we are here and why our field even exists is that we're hoping to reduce symptom burden in patients. And we do see that that is the case for most people. We're trying to improve patient and family satisfaction. We're improving the quality of life of people during their cancer, during their advanced illnesses, and again, reducing costs. Because like we already talked about, we know that it is very challenging to go through cancer and treatment. So specifically palliative care in neuro-oncology, and this is the American Society for Clinical Oncology, which universally recommends palliative care early, and that is what the neuro-oncology group, they reference this as well, is that anybody within 8 weeks after an advanced cancer diagnosis should be getting in with palliative care. And we're thinking about that for people, and especially with both inpatient and outpatient capabilities. So like our team here at AGH, we have inpatient at all of the different hospitals, and then we also have people that are working outpatient. One of the things that and reason that we worry about palliative care in neuro-oncology is that we know that people can be really sick. This is one article that I found that said that 42% of patients were admitted to the hospital within 1 month of their death, and a third of those patients were in the ICU. And most of the time, these admissions are related to their brain tumor and their end of life. And while we definitely respect some people are going to want to have, be in the hospital at the end of life, we also know that a lot of people don't want to be in the hospital at the end of their life. So it's important that we think about this before we get to that point. The other thing that we think about is symptoms. So symptoms in neuro-oncology are a bit different than your typical palliative care patients. There's a really, really high symptom burden for patients in neuro-oncology. About 50%, over 50% of patients have 10 or more symptoms. And obviously, we're not going to be able to fix every symptom that people have, but when they have so many symptoms and many of them are distressing for them, if there's some that we can assist with, that's what we want to be able to do to help alleviate some of the distress associated with their cancer. So some of the high-risk symptoms that we think about for neuro-oncology specifically that were the typical palliative care, we're thinking about pain, nausea, vomiting, appetite. And what we really see with neuro-oncology and these brain tumors is a difficulty with fatigue, difficulty with memory, sleep, cognitive impairments, depression, and all of these things that are kind of overarching and may not be thought of if you're just kind of going through the motions. A lot of people are tired, a lot of people aren't sleeping. There's a lot, it's normal to be anxious, it's normal to be depressed when you have major illnesses, but it's also important to think about them, talk about them, and make sure that we're addressing things and treating people as they want to be treated. Some of the barriers to care are similar just from neuro-oncology earlier. There also oftentimes is a provider discomfort with palliative care. There is a lack of palliative care providers just universally, like there are with neuro-oncologists, although there are way more palliative care providers than there are neuro-oncologists. And increased burden of extra visits, financial copays, where we don't want being seen and being helpful in symptoms to cause more distress in other ways. So getting back to our clinic here, you already heard from neuro-oncology, and we mentioned that we also have neurosurgery there and radiation oncology, and then there's me in palliative care. So I'm going to kind of go through a pretend case with you guys, just to kind of show where you may see me and how I may be helpful in different cases. So let's say we have a patient, he's 78, he comes to the hospital because he has a seizure. Family brings him in, he goes to the hospital, they do a bunch of scans, because they always do, and they find a big old brain tumor. They do a little bit more, they go do an MRI, definitely looks like cancer. Okay. Patient's like, I don't know, I'm 78. Do I really want to go forward? Like, do I want brain surgery? And so then that's when, I can come in right off the bat, immediately, even before we have a diagnosis here, to help talk. Who's their surrogate decision maker? Who's going to help them make these decisions? And how do we talk about what is the right path forward for you? So that might be talking about, what is your life like already? What is important to you? What are you kind of willing to risk? What are you willing to do for time with your family, with your friends? What is important here? So we have a conversation. Some people in this case are going to say, I'm already really not happy with my life. I've been doing a lot. It sounds horrible to try to go through a brain surgery, even to find out what this is. And then they may say, I don't want to go forward with it. And they may, go to hospice. A lot of people, most people, I think, would be like, I really want to know what this is. So we go forward and we get a biopsy. So for this specific patient, we can say we have a biopsy, confirms that they have a glioblastoma. So next steps are, we're going to be bringing them into our MDC. At that point, we're going to talk through, what is the treatment? What is the outcomes here? What are the risks? What are the benefits? What does this treatment look like for you? This guy, again, he's like, I'm not sure what I want to do. So we sit there, we talk, we say, okay, what is important to you? Is this worth it for you to do? And for most people, we try, to do some treatment. And so let's say he's like, all right, I'm gonna do treatment. I feel okay. I'm gonna go forward with it. He starts to get some symptoms. I see him. We, address his nausea. We address his fatigue. We help with the headaches. We help with some rashes. He tolerates treatment. He gets through the whole treatment, and now he is on surveillance. And so I check in. I'm like, check in every 3 months, see how he's doing, see if things are going okay, and be still available if you need me. So then 6 months later, as we know, very often somebody comes back, has more fatigue, appetite's poor, having headaches, now falling, do an extra MRI, and we see that the tumor is back. Now, again, we can have a discussion in our MDC. We can say, hey, we could go back to the OR, we can do surgery, we could think about other radiation, we can think about other chemotherapies, and is that the right choice? And for some people, again, the answer is yes. But for some people, the answer at this point, and I'm thinking for this guy is no. And he says, I'm okay with how I am. Can you just make sure that I'm comfortable? I wanted to spend the rest of my time with my dog at home. So at that point, we say, all right, no further treatments for your cancer. We're going to go and address your symptoms. We're going to refer you to hospice at this point. We get our nurses, they get that referral over to hospice right away. We can communicate with them and get them onto hospice smoothly. Patient doesn't have to go into the hospital for this. They get to go back home. We do all of this from home, and then they enjoy their time at home, do what they need to do, and eventually will pass away from the disease. But in this case, they're able to pass away at home because that was their wish. So in kind of a summary again, our goal with our multidisciplinary team is to improve patient access to care, helping to improve quality of life for both our patients and their families, increase our access to clinical trials, decrease some of this financial toxicity, and establish early goals in advanced care planning. These are just a couple of resources that I put on that I found helpful. There's the National Brain Tumor Society has a lot of information for patients. The American Brain Tumor Association also had a lot of information. And then the Center to Advance Palliative Care is a great resource for clinicians and for families to look at other resources for palliative care. And that's it for me. I think, do we have time for questions? There are any?
Yes, we do have time for questions. Let me tell you our first question. The first question is, I have heard in the past of new MRI, not sure if it's called links, in which the patient has radiation, MRI guided, and there was a study for glios. Any word on that study or results yet?
I think fair.
Yep.
Okay, so the question is about something called MR-Linac, which is linear. Linac means linear accelerator, and MR for MRI. Basically, the idea behind that, and I'm not a radiation oncologist, so I'm sure that one of them could give a much better description of it, but it allows the MRI to guide the radiation. So people being made of, biological stuff, things are not always in the exact shape in the exact places when you plan it. The MRI can allow really precise adjustments to the radiation. I know that they were working on getting one installed and set up at HEH. I don't know of any evidence. I don't know of data specifically for GBM to talk about different outcomes. It does tend to be it does tend to be more tolerable. It does have evidence that, we're able to reduce the dose that affects the healthy tissue. Whether that affects ultimate outcomes in brain tumors, I don't know offhand what the data would say for that. But hopefully something we'll be doing at AGH soon for brain tumors.
Okay, I have
I also
another.
wanted to note, I see someone raise their hand. We aren't able to have folks come off mute to speak. If you have a question, please go ahead and put it in the chat or the Q&A. Thank you.
Margie, Dr. Herbst, I have another question. That is, what resources do you recommend to address caregiver burden? Very good question.
Yeah, I'll take that one. Sorry. And sorry for the switching back and forth with the computer. Sounded a lot better in theory than probably in
I think it's working very well.
Thank you. So caregiver burnout is a huge problem. And overall, we know that helping kind of getting resources in is one of the biggest things for caregiver burnout. So typically what I've been doing here is trying to connect people with our resources with our social worker, trying to get people into other, sorry. What's the word I'm looking for? Support groups. Yeah, support groups throughout. And that's what I was looking at with that American Brain Tumor Association and other resources like that is where I usually start with.
Okay, I have another question. Does insurance pay for palliative/hospice at home?
That's a great question. So palliative care is not at home, although there are some like home-based programs where you have somebody coming in. But palliative care is just another subspecialist that you're seeing. So it would be charged the same way as your regular, copays for your doctor visits. Hospice care is totally separate. And when you elect for hospice care, that becomes like your insurance and it kind of takes over. Most insurances cover hospice 100%. Although some commercial insurances don't have 100% coverage, but the vast majority do. And that includes at home.
Okay. It looks like we don't have any other questions. So if there are no other questions, we would like to thank all of you for attending our Ahead of Cancer lecture this evening. Please continue to join our monthly Ahead of Cancer lecture series as we focus on cancer screening, early detection, treatment, and survivorship. As a reminder, tonight's lecture was recorded, and if you're interested in rewatching tonight's lecture, check back on our YouTube channel in about a week or so. It should be uploaded for the full recording. This video, as well as all of our other previous Ahead of Cancer lectures, are all under the AHN playlist. Lastly, I'd like to thank Dr. Herbst and Dr. Herbst for a great presentation tonight, and to thank all who attended this evening. Thank you for kicking off our 2026 Ahead of Cancer lecture series, Dr. Herbst and Dr. Herbst.
Thank
And
you for
have great
having me.
evenings, everybody. Thank you.
Thank you.
Bye.
Bye-bye.